practitioner student with Montana State University. I will be performing a focused musculoskeletal assessment on you today. This is being recorded. It is for educational purposes only. It will be viewed by my instructors and my peers. Is it okay for us to proceed?
Yes.
Great. Upon entering the room, I'm just taking note of my primary assessment, acknowledging any emergent concerns that I could have that would need to be tended to at this time. I would also be acknowledging my general survey. This would include overall appearance of health, height and weight proportion, level of consciousness, as well as hygiene and dress. At this time, I would review vital signs, or I would capture those if needed. And from there, I would begin the musculoskeletal exam. With that, I would start with the upper extremity. First, looking to inspect. I would do this by looking at the anterior shoulder girdle bilaterally. Here I'm looking for any obvious swelling, bony deformity, atrophy, fasciculations, or abnormal positioning. During this part of the exam, during the inspection, I will also be assessing the skin. So looking for any discoloration, any alterations such as lesions or any abnormal contours. So again, just assessing the anterior shoulder girdle. Then I would come and look posteriorly. I'm just assessing the scapula as well as the supporting musculature. From there, I would look down at the elbow. Paying particular attention to the joint capsules, looking for any obvious tenderness or nodules. Looking down at the wrist. Again, any obvious signs of redness, swelling, or nodules. From there, I would begin to palpate. I would first begin by identifying the sternoclavicular border and would palpate along the clavicle. Here I would identify the coracoid process. And then posteriorly, I would identify the scapular spine, palpating along that until I get to the acromion process. From here, I would want to palpate the greater tubercle, as well as the biceps tendon. And here I'm just looking to palpate the subdeltoid and the subacromion bursae. As well as posteriorly, I'm looking at the supraspinatus, the infraspinatus, and the teres minor. Any tenderness when I'm palpating? Okay, great. So moving to the elbow, here I'm going to be palpating the lateral and medial epicondyles, as well as the olecranon process and the ulnar nerve. any tenderness when you're palpating the elbows. And then moving down to the wrist. Excuse me. Here I would be palpating the radial and ulnar joints. Also looking at the snuff box here. I would be palpating the carpal bones, as well as the metacarpal bones. Again, paying attention to any tenderness and swelling. Then I would compress the metacarpal phalangeal joints. And press medially and laterally to the proximal and distal interphalangeal joints. Okay, so moving on to range of motion, we would start again up at the shoulders. So we'll go ahead and bring your arms out in front of you. Great, and up over your head. Great, and back down at your sides. Go ahead and bring those arms back behind you. Perfect for extension. Go ahead and, palms facing you. Go ahead and out at 90 degrees. Great, and go ahead and rotate your palms facing upwards and bring your arms up over your head. Great. Any pain with that motion? Okay, go ahead and bring your arms down to your side again. All right, and from here, go ahead and reach your arm across, just checking the AC joints here. Good, and with your other arm. Great, and with your elbows flexed at 90 degrees, if you go ahead and lift, good, and back down. Okay, and as much as you're able to, go ahead and reach behind you and touch your scapula. Good. And other arm. Great. Any pain with that? Okay. Should there have been any indication, I would have potentially pursued a nerve impingement or Hawkins impingement sign for any potential rotator cuff injury. Moving down to the elbows, go ahead and flex at 90 degrees. Great, and back down. Then bring your arms back up. Go ahead and face your palms to the sky and back down. Great. And then for your wrists, go ahead and bring your arms back up like this. And go ahead and, actually I'll have you get palms up to the sky. Go ahead and bring your palms towards you. Great. And down. Good. And go ahead and palms down. Go ahead and bring those hands in medially or in towards your center. Good. And then back out. Great. Okay. Any pain with that? Great. So then testing range of motion of the thumb. I'll have you go ahead and bring your thumb to the base of your pinky. Good. And go ahead and bring your thumb to the sky. Good. And go ahead and bring the thumb to the pads of each of your fingers. Great. Okay. And then to further test the fingers, go ahead and make a fist for me. Good fist. Good. And go ahead and fold those fingers kind of to the top of your palm there. Great. And go ahead and fold those fingers all the way over your palm. Good. And go ahead and bring those fingers wide and back together. Good. Any pain with any of the movements in your wrist and your hands?
No.
Great. If it was indicated here, I would look at Cullen's and or Phelan's sign for any potential carpal tunnel syndrome. And that would conclude the upper extremity. Excuse me. Moving into the spine, I'll have you go ahead and turn around for me. Okay, to begin the spine assessment, I would first begin by just taking a general appraisal of the position of the head as well as the neck and trunk posture. From there, I would be assessing for any abnormal cervical, thoracic, or lumbar concavities or convexities. Great. And I would also be looking for any abnormal lateral curvature of the spine from C7 down through the intergluteal cleft. It's important to note that in a proper assessment, we would have the patient in a gown where I would have a better visual of the spine. But here I'm just assessing for straightness. Great, and go ahead and bend at the hips and forward at the hips. Great, okay, and stand. As a part of my inspection as well, I would be looking at shoulder and hip alignment. I would also take the opportunity to palpate the iliac crest just to affirm alignment. Go ahead and bend forward at the hip again. From inspection, I would move to palpation. First, I would begin by palpating the spinous process. During this, I'd be looking for any midline tenderness as well as any step-offs. Any pain? From here, I would palpate the cervical facets. As well as the paravertebral musculature. Assessing for any tenderness and any muscle spasm. Any pain? I would also then palpate the sacroiliac joints, which would be potentially under any dimples. Okay. No pain? Great. Okay, go ahead and turn towards me. Following palpation, I would go ahead and test range of motion. From here, we'll start at the neck. Go ahead and bring your chin down to your chest. Good. And go ahead and look up at the sky. Great. Go ahead and look over your right shoulder. Great. And your left. Good. Now go ahead and bring your right ear to your right shoulder. Good. And your left. Great. Any pain with any of those movements? Great. From there, we'll test the range of motion of the spine. So we'll go ahead and, I know we've seen you do it before, but go ahead and bend just at the hip again forward. Great. That's great. And go ahead and bring your chest to the sky for extension. Great. And now go ahead and rotate your body over your right side. There you go. And to the left. Great. And go ahead and bend at the hip. Yep, to the right side. Good. And to the left. Great. Any pain with any of those movements? Great. With the range of motion, we're just looking for equal and non-limited movement. Without any further indication to palpate or inspect any other areas by the patient, we would then move on to finish off the musculoskeletal assessment. We will finish with the lower extremities. With this, I will start by inspecting the patient's gait. During this time, I will be looking for smooth and coordinated movements as part of the spinal assessment, and then I will also be looking for width of the stance as well as any shift of the hips and flexion of the knees. Go ahead and take some steps. From there, I would again inspect, also just taking note of any of those skin discolorations or alterations like lesions. In the hips, we're looking for any atrophy and bruising. Okay. Knees, we're looking for alignment, any obvious deformities, swelling. And in the ankles as well, looking for any swelling, nodules, any deformities, or any calluses as well. Okay. And to move on to palpation, we'll go ahead and again revisit the iliac crest. Any pain? Okay. Move on to the anterior iliac spine. Pain? And the posterior iliac spine. Superior iliac spine, excuse me. I would then also be palpating the greater trochanters, also just taking special caution with the left hip pain that the patient presented with. Knee pain? From there, I would also take this time to palpate the left trochanteric bursa. At this time, I would have the patient lie on their right side with their hip flexed with some internal rotation, and I would palpate the left inferior gluteal cleft to assess that bursa with left hip pain. From there, I'll go ahead and have you take a seat for me. I would be just assessing the way that the patient is able to sit and squat for range of motion. From here, we'll be assessing the knee. I would be assessing the patella as well as tracing the patella and the patellar tendon down to the tibial tuberosity. I would be palpating the femoral, the tibiofemoral joints, as well as the medial and lateral femoral condyles. Also just assessing for any atrophy, any pain in the thigh. I would be assessing the collateral, medial and lateral collateral ligaments. The menisci. As well as the pre and supra patellar bursae. From here, we would palpate the ankles here. palpating the medial and lateral malleoli, the Achilles tendon, looking for any nodules, swelling, tenderness. So also the posterior and inferior calcaneus. Any tenderness. As well as the plantar fascia. Any tenderness here? Tenderness here. As well as compression of the metatarsal phalangeal joints. Okay. I'm looking for any nodules, tenderness with those joints, as well as the head of the metatarsals. Okay. Okay. Following palpation, we would go ahead and test range of motion. So if you want to go ahead and stand with them for me. We'll first start again up at the hip. So you'll go ahead and bring your leg out in front of you. Go ahead and bring your knee up. There you go. And go ahead and bring that leg back. Good. And do you feel like your balance is okay? Okay. And so then go ahead and do your right and bring your knee up. Okay. Great. And go ahead and bring your, we can start with your left. Go ahead and bring that leg out and back in. And go ahead and your right. Perfect. That feels okay. Great. And see from there, if possible here, I'll give you this something to hold on to. Go ahead and bring your knee up. And go ahead and bring that knee out. Good. And go ahead and do it with that other leg. Up and out. Great. Okay. And to assess the rest of the legs, we'll have you go ahead and take another seat. Okay. And for this, for assessing the range of motion of the knees, go ahead and bring your extend. We'll start with your left. Great. And back down. Your right. Good. Okay. And if possible, I'm going to help you kind of hold your leg. I want you to rotate your lower leg inward. Good. And outward. Good. That feels okay? Mm-hmm. Great. And inward and outward. Good. Feels okay. Yeah. Great. Okay. To assess the ankle, I'll have you go ahead and we'll do dorsiflexion. So bring your, we'll start on this side. Go ahead and bring your toes kind of up. There you go. And back down, kind of point towards the floor. Good. And this side, back up and down towards the floor. Great. And I'm going to go ahead and hold this out here for you and kind of hold this steady. Go ahead and do your best to only bring your foot inward. Good. And outward. Great. And now go ahead and if you can, bring your, kind of rotate. There you go. Just like that. And rotate inward if you can. Good. And we'll do the same on your left. Okay, and so did we already, go ahead and we already flexed and planted, I think. Okay, so go ahead and bring your toes up to the sky and point. Perfect. And go ahead and I'll try and hold your legs steady here. Go ahead and bring your toes inward and outward. Good. Now if you can, kind of rotate your entire foot. There you go. And outward as best we can. Great. All right, no pain with any of those movements? No. Great. If my assessment had indicated at any time, we could potentially, if there was bodiness, swelling, tenderness, any bone enlargement, things like that, we would assess further. So for the knees, if we were concerned We could look for look for bulge sign. For any effusion, we could also, for meniscus injury, we could pursue a McMurray's test. For a ligamentous injury, we could do a stress test, a valgus stress test. And then for the ankle, if we were concerned about a ligamentous injury, we would do an anterior drawer. So that concludes our focused musculoskeletal exam. Thank you for allowing us to do so.